Greetings, everyone. We'll begin shortly.
Hello, everybody. Thank you for joining today's webinar. My name is Cynthia Klein, and I serve as the Project Director for Take Heart. We really appreciate you joining us today, and we hope that everybody is safe and well. We'll be led today by Dr. Hisham Scally and Stephen Hines, who you've had the opportunity to hear from in past affinity groups and webinars. We'll also have a number of your hospital colleagues joining us today for the affinity group. Jean, on the second slide, we do have a couple of updates we just wanted to provide on Take Heart before we move into the rest of the presentation. Some of the announcements, I've got 3 of them. So the first announcement is that we have launched and we will continue to grow the Resource Center on the Take Heart public website. On this website, we had originally put the cardiac rehab, the Million Hearts cardiac rehab change package has been the main focus of the Resource Center. We've since continued to do an environmental scan and literature review and have populated it with some additional resources. Those resources are really focused on referral and enrollment and retention in cardiac rehab, so you'll find those resources there. The second announcement is that we've also continued to expand the offerings that we have on our private website. So we've called the private website also the online collaboration workspace. On the private site, you'll be able to see COVID-specific materials from past affinity groups that we've been holding over the last several months. That includes past slide decks. It includes event summaries from the past affinity groups as well. Also within that private site are some COVID-related resources that have emerged over the last several months. And then really part of the reason it's on the collaboration workspace is it gives that opportunity for discussion. So there are several discussion threads that have led out of some of these past affinity groups so that we can continue the discussion after they've ended. We encourage anybody to go ahead and, obtain access to the private site, and you can do so by reaching us at takeheart@aptassoc.com, and Aptassoc is ABTASSOC.com. Anybody can have access, but we do need to grant access in order for you to be able to get that part of the website. And then the last announcement I have is if you are a partner hospital from Cohort 1, you have received or you will shortly be receiving some outreach from your coach. We'd be really interested in just scheduling a brief discussion with you over the next week or 2 by phone, just to check in and see how you're doing and discuss options for resuming operations perhaps in the fall or beyond. So please be on the lookout for that outreach from your coach, and we'd love to touch base with you. All right, I think that's everything I have for announcements. Steve, I wanted to go ahead and pass it to you if you're ready to take it away.
Excellent. Thank you very much, Cynthia. And Hisham, if we could take a look at slide 3, and so I can make a few comments about today's event. We just want to remind you that these affinity group sessions are really forums for everyone in the Take Heart community to learn from each other, to share with each other, and to support each other. And we've been really happy with how that's gone on past events, with people asking questions, getting insights shared in the chat and from the panelists, and really fostering a supportive environment that's just so critical with the many other things going on in the world right now. We want to continue those processes today, focusing on strategies for how cardiac rehabilitation programs are adjusting to support patients in the periods of time that are very frequently being lengthened between their on-site visits. And the panelists that we have today have some very useful insights to share with that. We'll use a moderated panel discussion led by Dr. Scali, who we're delighted to have in that role again. Dr. Randy Thomas, who's the medical director for the Mayo Clinic Cardiac Rehabilitation Program in Rochester, Minnesota, is going to be sharing his insights both on what's going on in his program as well as his sense of what's going on nationally. Jesse Hyduk is the cardiopulmonary rehabilitation supervisor at St. Joseph's Regional Medical Center in South Bend, Indiana, where she supports that community as well as Notre Dame University and people from that school. Laura Vaughn is at the McLaren Greater Lansing Cardiac Rehabilitation Program in Lansing, Michigan. And then we're very happy that Tricia McNair is joining us today. Tricia is a graduate of a cardiac rehabilitation program that has some really useful insights on the patient's perspective that we want to make sure is reflected. Since after all, whatever adjustments that you're making in your programs, if they're not accounting for patients' needs and the challenges that patients are experiencing in their environments, then they're not going to work as well as they should. So we want to make sure that that is reflected. And then we're also delighted to have Karen Louie on the phone. She's a regulatory analyst that's going to be able to provide an update on proposed CMS Medicare rules change that impacts or may impact cardiac rehabilitation programs. Obviously, it's been a challenge for cardiac rehab programs to support patients for services that they provide not on site through virtual means, webinar, or phone-based services. And the proposed rule has some implications for that. We don't advocate for or against proposed rules, but we do support CMS's efforts to get comments from providers about the impacts that their proposed regs would have on facilities. So to do that, we want to encourage you throughout the event to participate in the conversation using the chat function. Make sure that if you go to the right icon on your control panel and open the chat box, please check the all participants option because that's the option that lets both your peers in the audience see the things that you're saying or the questions that you're asking, and then lets everyone that's on the panel see them as well. So if you can click that, then we would love for you to have a chat, to see your chat questions. Feel free to try it out. Just send a short greetings to the group and see how it works so that when you have a question later on or a comment, you're comfortable using the technologies. So beyond that, we also are going to be asking a few polling questions. And we want to make you aware of the polling function because it's a good chance for our panel to see what's going on. AHRQ and CDC are very interested in the current status of things. So we'll start off with the first polling question, which is one that we've used on many of these past events, just to get a sense for the current status of your hospital's cardiac rehabilitation program. So if you can just pick whichever of those 4 answers is most appropriate and click that response, and then make sure that you click submit when you finish so that it's registered. So if you can enter those things, we'll give you a few more seconds to do that. and then we'll close out the poll and see where things currently stand. There's been a lot of change since we started these events in April, with more of them opening up, but a lot of variability and some unfortunate needs to reduce capacity as the pandemic has surged in some places. All right, if we can close out that polling question and briefly see the responses to it, that would be great before we move on to the next polling question. And this takes just a few seconds to for the WebEx technology to do the mental response calculations. All right, so 65%, 2/3 of you are operating reasonably normally, which is great news, with most of the rest of you having limited patient visits. So that's good to know, but we understand that reasonably normal operations also include some significant restrictions that we'll talk about in a bit. All right, the second polling question. We're just interested, as you look into your crystal ball and think about the future, how likely is it that your program may need to reduce your level of on-site operations at some point between now and the end of the year due to a resurgence of COVID-19 in your area? So if you could tell us what your crystal ball is telling you about your area and your program, and what it's likely to need to do between now and the end of the year. This will help us as we plan for future affinity group sessions and consider when we should be resuming the automatic referral training that many of you are participating in. All right, remember to hit submit, and Teresa, if we can close out that polling question and take a look at the results for that, that would be great. All right, so looks like maybe about half of you, a little more than half of you, think it's somewhat or very likely. That is about the same, perhaps a bit less than on our event a month ago, so that's good news. Obviously, none of us know exactly what the future holds. But let's move on to our third question before we get into the meat of our discussion today. So we're very interested in the changes that you're making in the frequency with which you're seeing patients. So if you could tell us whether you're continuing to see most of your patients on site 3 times a week, or seeing most of them maybe only once a week on a weekly basis, once or twice, or seeing them on site less than once a week, or it's just sort of not a regular schedule, but it's irregular intervals just based on when patients are capable of coming in and on when you have the slots to support them. And if you're not doing any of those things because you're not seeing patients on site, you can click that last option. So if you can click that and hit submit, then if we can close out that question and take a look at the results, that will be very useful for our panelists today. All right, so 2/3 of you are seeing patients on site 3 times a week, with the rest split across the other categories. So, so it looks like a significant majority of you are seeing patients at least once a month, once a week, if not more frequently than that. And that's obviously very good news for both your programs and your patients. All right, thanks very much. At this point, I want to turn the moderating over to Hisham, and he can talk us through the categories and then lead us into a discussion with Karen about the changes in billability.
Hi, everyone. Thank you, Stephen. And I want to welcome all 131 participants on the webinar today. And I look forward to a lively and insightful discussion with all our panelists and all of you through our chat box. So these are the 5 categories of our topic that we'd like to approach today. And we'll start with the presumed changes in the Medicare availability due to how we are doing our patient care in cardiac rehab currently with a lot of the non-in-person care. And eventually we'll talk about changes in the unit capacity, so how we have changed our operations and how we have changed our scheduling, as well as how we are taking care of patients in between visits, how we are supporting them, how we are keeping our staff busy, and then we'll talk about the changes in how the patients are conducting their visits with us, and how we are changing the schedules and the way the sessions are going on. And eventually we'll conclude by talking about how we have learned so far from these challenges and this adaptability that we have been forced to perform so far. So without further ado, I know that time is running, and I'd like to welcome Karen Louie, who's been a excellent and long-time clinical practitioner of cardiac rehab and a big advocate in that field as well, both within and outside of AACVPR. So Karen, thank you very much for being with us. And just to set the stage, could I ask you what changes is Medicare considering in terms of the billability of the cardiac rehab services?
Much. I think I was told I have about 5 or 10 minutes, perhaps, to go over what we know and what we don't know from a CMS regulation perspective. So in a nutshell, since March, through the rising public health emergency and beyond, here's what we know. In mid-March, our programs were closed, staff relocated, redirected. Some programs were relocated from precious hospital space by need to some off-campus location or other spaces around the area of the hospital, and that was being allowed. As flexibilities to provide patient care progressed over time, CMS received multiple requests from a number of professional organizations, our partner organizations and us, to allow cardiac and pulmonary rehab to use telehealth codes to deliver cardiac and pulmonary rehab. That was not granted. They remained silent despite multiple letters, inquiries, requests for call, so it was not answered. On March 31st, however, CMS expanded the direct physician supervision to include physician availability via virtual audio-visual real-time technology during the PHE. This at least allowed programs who'd been moved out of the hospital, to the vicinity where location could be where there's not really a doctor physically available, the opportunity to continue providing the service with that virtual physician supervision. Keep in mind with this, cardiac and pulmonary rehab are different than most hospital outpatient services, which are under general supervision and don't have a requirement statute in place, where the direct physician supervision for our services requires immediate physical availability, and that's where the hang-up has been. So letters continued to be sent to Congress, to CMS, urging virtual delivery of cardiac rehab services. What we know, cardiac and pulmonary rehab are not eligible for telehealth codes. That's because it's been clear in the flexibilities offered, the telehealth codes are for practitioners, physicians, qualified health practitioners, that's QHPs. That includes any practitioner who can, under the physician fee schedule, independently bill for their services. For example, licensed psychologists, nutritionists, nurse practitioners, physician assistants, PT and OT fall under the physician fee schedule system, even though they don't generally bill independently. You see the difference because our services are provided by clinical staff who are not in that realm of being able to bill independently for the services we provide in cardiac and pulmonary rehab. In April, CMS allowed some hospital services then to deliver service to home, which they saw as the equivalent of a provider-based department. Now, cardiac rehab, pulmonary rehab were not on any list of some of those services. There was a list of examples of services, but cardiac and pulmonary rehab were not on that. So what do we know? Yesterday, the formal Federal Register published the 2021 Outpatient Prospective Payment Proposed Regulations. We did get a little early release on August 3rd, so what we knew was coming yesterday we were aware of. And that states that effective January 1st, 2021, that statute that requires the physical presence of the supervising physician will be changed, and that language physically removed to say replaced with real-time audiovisual technology throughout the performance of the procedure. We think that's good news, but what we don't know, keep in mind, nowhere in any of the CMS discussions of the virtual physician direct supervision is there any reference or guidance regarding where the service can be delivered. They have been totally silent on this, with only the physician supervision addressed. So our questions are, does CMS imply that during the public health emergency, we too can interpret that home equals provider-based department for our services, despite the physical availability catch? Does CMS imply that it's okay to ignore that physically available statute that our proposed regulation states is effective on January 1st, 2021, if the final reg matches what has been proposed? And the final reg comes in November. So AACVPR and our fellow organizations will submit public comments in the near future, and we will post those on the AHRQ website, asking for a clear, concise answer to these questions. And they generally don't comment until the final regulation is published, because we have a period of time to anyone can submit public comments, and then they have a period of time to read and respond to all those comments in the final regulation. So until then, AACVPR must defer to your hospital compliance department to interpret this opaque CMS guidance. Whether your institution or organization agrees or doesn't agree with the AACVPR requests of CMS in our submitted public comments, we do encourage you, as mentioned earlier, to please also submit public comments. We hope it's a united voice with a similar vein, but that is totally up to your institution and whoever is submitting those comments. CMS does really respond to those, and it's very interesting reading. Hopefully it's an optimistic response and a clear one. You know, we're stuck in a spot here. No one wants to be doing something that's fraudulent, or some of us are uncomfortable going on implied assumptions that delivering this service remotely is okay. Again, back to an institutional decision, and we certainly need clarity from CMS on what they meant, and we will get that in November. That's my situation in a nutshell. Thanks.
Thank you, Karen, for explaining a a complex situation and making it more graspable for many of us. It is a change from CMS, but as you said, we won't have much more clarity until November about a few of the perspectives that you raised, the issues that you've raised about how is a physical, the audiovisual supervision by the physician, where is that provided, and compare it to where the service is provided, whether it's at home or not, and whether that extends beyond the PHE or not. So I guess it's a stay tuned for now. And as you said, looking at using the period that we have to write our comments and send our comments to CMS until we see where that lands us. Before I move on to the rest of our program, I just want to ask if any of the panelists has anything to add to what you just said about the CMS, the new CMS rules. So Randy, Jesse, or Laura, as practitioners, do you have anything to add about this last topic?
This is Laura. I do.
Yeah, please.
I just want to make sure that everyone knows that anyone can make a comment to the Federal Register about that regulation. So all you have to do is visit the website and explain how it will impact your program, and then ask a question. And like Karen said, they do respond to you.
Thanks.
Great. Excellent points. Good. So with that, let's move on to the next topic about how we have changed our unit capacity. And I'd like to start with Jesse in South Bend, Indiana, how you have changed your, how you have reduced your program capacity, which patients have you prioritized to see, and how frequently are you conducting your visits? I know you have a relatively large program, so please go ahead, tell us how you've been doing this, and thank you for being with us.
Well, thanks, Hisham, for having me. So here in South Bend, we've actually reduced our capacity by about 50 or 60% currently. So we've gone from seeing 820 visits a month, and we're currently averaging about 266 as we start to get up and running again here in South Bend. And that is just our cardiac and PAD programs. We have not even brought our pulmonary program back yet, and we don't know if or how we're going to, given the new space constraints we're under. So we have a lot that we can change and do moving forward, depending on what's going on in the world. When it comes to prioritization of our patients and how we enroll them given the limited capacity, we really just do it on a first come, first serve. And then if we really comes down to it, we'll go to our medical director or the physician and ask their opinion on the feasibility of the patient, the risk of the patient, to get their input and their backing. Because we all know that if the patients hear from the physician that they want them to do it, that there's a little bit more clout for them to really follow through with the program. And with that, we've been really looking at how long the patients stay in the program. So those that are more active, have a really good handle on things, we're also discharging earlier when it comes to that prioritization within the program. And we are seeing our patients currently, for the first 30 days, we are really hitting them hard. We're having them come twice a week for 90 minutes. So we can do about 40 to 60 minutes of exercise and anywhere from 30 to 40 minutes of education. And hit them hard, hit them early on. And then once we hit that 30-day ITP, we reduce them to once a week for 90 minutes. And to fill the gaps, we give them homework that they fulfill while they're not with us.
Great. So that's rather a change from what you've been doing before, like extending their sessions and then really, as you said, hitting them hard in the first month and then accommodating every patient based on how they're performing, even releasing them earlier if they're doing well. Very good. Very good. Laura, in Lansing, Michigan, you also have a relatively large program and that has seen a lot of changes. Do you want to tell us about your experience?
Sure. We similarly sized, as you said, to Jessica's program. We see about typically 250 to 270 new phase 2 patients a year, and that ends up being somewhere between 500 and 600 phase 2 visits a month. And we're actually getting close to that with our volume now, incentivized by our administration to get those numbers up. So we've brought our patients back. We started out with, okay, we're going to bring our high-risk people in so that we can have that patient contact with them. Our heart failures and our open hearts, you know, they need to see us more frequently. And then we were trying to prioritize, okay, these people can come 3 times a week, these people only once a week. But with, like I said, that incentive to increase volumes, we're back to mostly bringing as many people as are willing to come in 3 times a week. But then same as Jessica said, trying to individualize that to an extent so that we're having more frequent contact with the people who need it the most, who need more education and who maybe aren't doing as well with exercise on their own. And then the sort of younger, more fit, more health conscious patients, titrating them down to once a week.
Okay, very good. And so when you see them only once a week, just as an example, what do you ask them to do in between?
Oh, definitely homework. We give everybody their individualized home exercise prescription, explain very clearly, you know, the inverse relationship between MET capacity and risk, and make sure that they understand caloric expenditure if weight loss is their goal. And then we're trying to get people earlier on into being referred to other services. So getting people to their diabetes education program, getting people to see the dietitian, trying to get our smokers early into so that they've completed those other programs before their time is up with us.
Excellent. Very good. So you keep that momentum going, even though you're spacing out the visit, you keep the momentum of what they're doing in between. Thank you. Brandy, thank you for being with us. And from what I understand, you haven't been seeing a lot of patients in face-to-face visits so far. So please tell us what you've been doing, how you've been continuing your cardiac rehab practice so far.
Yeah, sure. Thanks for inviting me to participate. We actually are continuing to see patients or continuing to take care of patients in cardiac rehabilitation. It's just that we are continuing to do that through a home-based remote model. And actually, just the kind of unique practice that we have here at Mayo Clinic, where we have a number of people from outside the area who come here for care, our practice has actually increased, even though we're still entirely home-based. Just as background, the Mayo Clinic has been back seeing patients pretty much as we regularly do for 2+ months, probably close to 3 months. Our volumes are very high, including surgical volumes, et cetera. So the number of people coming in who need cardiac rehabilitation has continued to be high. We went from having, we typically see about 500 patients, local patients, per year in our program. There's about 2,000 non-local patients who come here for surgery and so forth, who we refer to their home rehab programs. But during this time, we've actually been offering the home-based program to the non-local patients as well. So our program actually increased by about 40 to 50% because we're including those non-local patients in the care too. But we've done some research here looking at safety of exercise with masks, without masks, group settings, et cetera. And our local infection control team has not given us approval to begin having people come in person to exercise yet. We have some things that we're working on to make that even safer. Basically, we have exercise pods that we're creating for each of our patients to exercise in that'll make it as safe as possible. We have about 21 cardiac rehabilitation programs in the Mayo Clinic enterprise throughout the United States, and we're the only one, as far as I know, that is not open yet. So most of the other centers have been seeing patients in a limited fashion on site, but our program has not as of yet. But again, we're taking care of patients remotely, busier than ever. We just made a shift to that home-based approach, and hopefully we'll have some patients coming back on site before too long.
Excellent, thank you. I know you've been a big proponent of the home-based rehab program and one of the co-authors on the state guideline statements for that. So I know this is one of the areas that we will see a big increase, hopefully, especially if the CMS rule changes in that regard.
Yeah, maybe I could say something on that too. The research is so strong on center-based cardiac rehabilitation. We certainly recommend that as a first-line approach when possible, and we will continue to do that longer term as well. But in looking at what's been happening for the past few decades, we see that participation rates in cardiac rehabilitation have remained low, unfortunately. There's a large number of people who just can't make it into a center, and those are patients, especially if they're low to moderate risk, or they're stable. Those are the ones who would benefit from a home-based approach if available. But certainly we want to make sure all patients have the opportunity for a center-based approach when possible.
Yep, absolutely. Very good. And let's get another perspective, and now from a patient, Tricia, who was presented in the beginning. Tricia McNair is a graduate of cardiac rehab. And Tricia, could you please tell us what's your experience been so far? Thank you for being with us.
You're welcome. Thank you for asking me, actually. I was very fortunate, I guess. I feel like I'm fortunate to be at MGH because it was such a comprehensive program. And I think the biggest thing for me was realizing that this is not just exercising. You know, as an executive at one of the companies, I just initially felt like I didn't have time for this. But it turns out when I really needed time for it, it was important. I found out this was a great program because they initially, there's a comprehensive review. They do a risk assessment, including, a physical exam they do. This is all in the beginning. The exercise tolerance test, they do a nutrition evaluation. And of course, they have lab tests and other like psychological or psychosocial, they call it, I guess, assessment. So that was great. And then the next thing was understanding my exercise program. And a nurse, we had a nurse, we call a nurse case manager. And the one I had saved my life.
Wow.
I would never forget it because I was on my way to cardiac rehab and I started to regurgitate and it was not good. And I didn't pull over. I continued to go to cardiac rehab. And I walked in the door and she knew right away something was wrong. And I kept saying, oh, no, I'll be fine. But the nice thing about being at cardiac rehab, she could immediately call my doctor. She could pull up my medical assessment. And then because we had this relationship, I said, okay, I really don't feel well. I'm gonna go ahead and go. And I ended up in the emergency room. And then the next day, or that same day, I can't remember, I had a stent put in.
Oh. Very good. Thank you, Tricia. I mean, this is, again, stresses the importance of how the patients and the staff actually relate and how that relationship is very important. And when you know the patient, you can feel the change, you can see the change, and you can actually address and recommend the proper evaluation. And I would suppose, as Dr. Thomas mentioned, that the benefits of cardiac rehab, whether it be face-to-face, in-person, or remote, will continue. But it's that relationship, that continuous monitoring, whether it's weekly, twice weekly, or so, that allows this improvement in outcomes and monitoring of this change in symptoms. And so,
well, I just want to say one other thing, Ken.
Please.
What was important also was the nutrition classes that we had. They were 8 sessions, so. And then we had an educational on-call session, which were 8-part series as well. Those 2 things, I ended up losing 60 pounds.
Wow, impressive.
Right. All due to cardiac rehab. So.
Well, yes, all due to cardiac rehab and your hard work and the staff over there. And so that's what, again, stresses the benefits of attending cardiac rehab and working hard and following the recommendations of the clinicians taking care and doing the work yourself. Nobody else does it but you follow those recommendations. So thank you for this reporting and for sharing your experience. And talking about patients, and I'd like to have our panelists comment on how they have changed the conducting of the cardiac rehab session and how the patient experience has changed with that. Let me start with Laura. How have you been changing the way you do this on a day-to-day basis?
Thank you. We've made some pretty significant changes to our daily practices. Sort of having to rethink everything was just like the nudge that we needed to institute changes that we had thought about or kicked around for years. So, not doing a blood pressure check on every single person 3 times every single time they come, utilizing the unmonitored sessions for people who are low risk, using the 90-minute sessions so that people can get 2 sort of visits in 1 appearance, and then spending actually more time educating one-on-one because we find ourselves with less people in the gym at any given time, able to spend more quality time with each person as they come through the door.
Yep, absolutely. Extending the time allows you to actually maybe get more messaging through. Jesse, what have you changed? How have you changed your practice?
So we went from having patients come twice a week for 60 minutes to now doing the 91-minute sessions once or twice a week, depending on what the patient can do and what our schedule allows, which has allowed us to focus a little bit more on education. We previously would do education for maybe 10 or 15 minutes each time the patients were here in that group format as they were being discharged from their session. But now we have a concentrated 30, sometimes 40 minutes of education that involves videos, it's hands-on, it's interactive. We've actually found some really cool resources online from Baylor Med School that have allowed us, for nutrition, that have allowed the patients to fill a grocery cart and then have to read labels and pick which food is the best or which food is the worst or what on the label doesn't make sense for a cardiac patient. And it's really prompted some great discussions amongst the patients, and they've really heeded that and taken the reins on our education topics sometimes, rather than us always being the teacher or the lecturer, which has been really cool to see. And that has allowed us to provide the support to them that they don't necessarily have on the gym floor, being so spread apart now. So we've seen a big change in the way that we deliver the services, and we've gone from a more segmented staff with part-time help to really a cohesive 3 staff members that are all full-time, so the patients know who to expect when they're here on a daily basis.
Good. No, that's very insightful, and sharing those resources. I mean, finding resources from all over and being able to share that with patients is extremely, I think, insightful and innovative. I mean, we haven't done that in the past. So in the last 6 months or so, we've noticed that people are really looking for all the help they can and all the resources they can, and sharing that amongst practitioners and with patients. So I think that we're seeing a shift in the way we do these things. Randy, I know, as you said, you haven't been, your program has been very active, but not face-to-face directly with patients, but I think you are making plans to when you do that. So what are you working on to do when you start seeing patients?
Yeah, so we've made plans and are awaiting the opportunity to put them into practice that are similar to the ones that have been mentioned by others, where we will have patients come in usually once a week and have more limited face-to-face interactions, or at least trying to minimize that where possible. Really focusing on those things that need to be done in person, and we'll continue to have the remote connections with our patients at least once a week as they keep coming in for in-person visits at least once a week. So nothing much more to add than what others have said, but and just careful and more efficient planning of our staff and patient interactions will be the main change we'll make.
Good, thank you. And Tricia, what have you noticed in terms of the practice and your visits with since COVID?
Well, I graduated before then, but I do know some of the changes that happened. It's going from 2 days a week. When I came back, it was we were at 3, went back to 2 days a week. And that was actually okay, beneficial. Because during that time when you go home, you have a home plan, every week. And so that exercise plan, what you ate, the duration of those exercises as well. So 2 times a week gives you the chance to connect again, just because the program was Monday and Wednesday. So you're going to go 4 days without, going there. And to me, that was always an issue. But now you get used to it. 2 times a week is perfect. 1 time a week, not so good. If you want to, but you have to prioritize. And I think that's important, because it is possible 1 time a week, if it's comprehensive and you give them that security that you're there for them, that you could, they can call you or whatever, or you can be on Zoom with them if they have a question, just as we do with the physicians at MGH. That's great. What I hope doesn't happen is if we go to 1 time a week, people will say, well, that's an exercise program, because it's not, and at the gym, you don't have, nurses, don't have a comprehensive team. That's important to stress. It's what you offer to a patient, even if you go 1 time a week, how you can check in with us, which I thought was great, and, be able to have Zoom, because that's the world we live in. So
Yep.
That's be the things I would say. If you do 1 time a week, try to set up a meeting with the nutritionist, because we have nutritionist classes, and just someone that they can check in with to see, how are you doing, right? 2 times a week, I don't think you have to do that. You don't have to check in or check on them, because they're there twice a week, and that was beautiful. So, but if it's once a week, I just want to reemphasize that. But if it's once a week, please try to have a day in the week that you just check up, see how they're doing. Twice a week, I said no problem. 3 times a week, no problem. You don't have to check in.
Thanks, Trisha. I think that's an important advice to keep that, again, connection going. If you see them only once a week in those 7 days or between those visits, patients might lose track, might lose momentum, might lose an incentive to keep at it and keep doing their work. So I think that increasing that another contact in between might be all they need to keep them working and keeping them healthy. And so that gets us to the next topic, which is how are we doing to support patients in between visits? And so I know we addressed some of these so far, but I'd like to hear it more specifically now from Laura. So are you doing this by phone? Are you doing it electronically via, I don't know if you have an EHR with the patient contact platform or some other ways? How are you doing this?
We're mostly doing it by phone. Just making sure that I say to every person, we all say to every person before they leave, you don't have to wait till your next visit to talk to me. You can call me. And then with people who are tech savvy enough, exchanging email addresses, and then we can forward videos or slides or a good web resource, and then making that sort of part of their homework is like, okay, read this or watch this, and then the next time I see you, we're going to talk about it and have go over any questions that you have. And then also trying to have sort of naturally, this has happened, we have more contact with the physicians. So, and I don't know if that's just a product of, again, having fewer people in the gym, so it's easier to access the EMR to send messages back and forth. But the patients love that. They love that I say to them, I'm going to let, Dr. So-and-so know that this happened today. I don't think it's anything that you want to worry about, but we're just going to make him aware of it. And they like that they're kind of go-between when you need to be.
My mute button was stuck. Sorry about that, guys. Jesse, how have you been doing it in your area? How have you been keeping contact with patients, and what have you been telling them?
So when they aren't here for a week, we really don't have anything set in place to constantly be reaching out in that week interim. So Tricia, thank you for that bit of information that you think that would be really helpful for keeping them really interested in the program. We have a department email address that we've been starting to disperse to patients that we recently acquired so that it allows us to send them information just like Laura talked about that could be helpful in that week off. But after that 30-day period where we decrease them to once a week, we introduce them to what's called Thrive from the Cardiac College out of Toronto. And we've just started implementing this in the last month, so we don't have much feedback from patients yet in regards to how they're using it or if they're using it. But it's a 12-week program, basically, where they have 12 different areas of their lifestyle that they can focus on for the week. And it walks them through with a video. It allows them to set goals for the week for themselves. And then it allows them to reflect back on those goals and how they did throughout that week with the facet of their life that they wanted to focus on. And so the staff have found it helpful, but it also puts more accountability on them to do a little bit more on their own. And it generally will loop in with our homework concept that we give them to work on while they're not with us in the department. And so part of our progress notes are what the homework was for the patient. So it kind of takes you back to, your old school, going back into school and having homework that you have to go to the teacher with. So we check in on them and we say, okay, your homework was to read a label this week. How did you do? Did you find anything that was crazy, out of the normal? Did you learn anything new? Did you make a different food choice because you read the label this week? So it's been really insightful for some of the patients who are doing the homework and following through. And then it's been fun to see some of the eagerness from patients. So like, okay, what's my assignment this week? What can I work on this week? And come back to us with a story or how they got a family member involved the following week.
Good, excellent. So that confirms really what Tricia was saying, sharing with us, and that's why it's very insightful to have a patient experience there. And so, Randy, when you start seeing patients, or currently with your home-based program, are you seeing, or are you doing the home-based program on a regular schedule with set visits, or are you also in contact with patients in between those program scheduled visits?
Yeah, we have a set protocol. It's very similar to our center-based protocol, where we have education and guidance, counseling, exercise prescription, treatment plan, et cetera. There's a weekly touch base and then other calls as needed. These are all done by telephone calls. And we have it's a 12-week program. And then when they graduate, we offer to our local patients a maintenance program for the subsequent year to make sure that we're keeping connected with them to help them continue their progress. One thing I'd say that I've noticed, and some others have probably noticed this too, when we have our center-based programs, patients come in for maybe 3 sessions per week. And unfortunately, even though we try to help our patients do exercise and continue with efforts outside of the program as well, we still find that many patients only exercise on the days they're coming into the center. What we've noticed with the home-based approach is the patients are doing much better at getting the daily activity in. And I think that there's a little bit more self-discipline, a little bit more expectation that they're going to be doing more every day or most days. So it's been an added bonus to what we've been seeing, and it's helped us to see ways we can help our patients in the future who come in for the center-based approach to help them do better when they're at home.
Excellent. It is possible that home-based program puts a lot of the responsibility on the patient's shoulder. Maybe that motivates them actually in keeping that momentum going throughout the week, and not just in between, not just for the visits in the in-center program. Tricia, anything to add for that? For this segment about how you can create social connections and appointments, if that's missing in this COVID era?
Yes. So one of the things that happen for patients, the first 3 weeks we get to know each other. So you can't make that connection unless you know that person. You won't do it. So the first 3 weeks is when we connect with the nurses, so we feel more comfortable. We connect with the patient, other patients is the biggest thing, because we look for each other. And when things aren't going well, we talk to each other. We talk to each other about things that we don't talk to, the staff about. And that's motivating because, for example, I had a guy that was in the class and he didn't want to go to nutrition class every Wednesday. And I would say, come on, you're going with me. So he would go.
Okay.
So what I would suggest is let somehow find a way that everyone can meet, exchange phone numbers if they wish to, emails. So that leaves it up to them to connect. And they also can, we have a program at MGH where the nutritionist is on YouTube. So you can, partner together and say, hey, let's go on YouTube to see the nutritionist and talk about it afterwards. So those are the kind of things people wanted to talk to each other because we're at home now.
Yep.
So, you tell us to go to YouTube and we can be together, or we at least meet that person, the first 2 or 3 times. I think it makes it a lot comfortable.
Yeah, no, I agree with you. I think that peer support from the patients is extremely important, and that connection may be lost when you're not seeing patients in a class setting. But certainly, we can try to not completely, but at least try to replace some of that in a virtual setting. And so that's probably one of the biggest lessons we're learning. And so just to conclude, I know we're nearly at the top of the hour. In maybe 30 seconds, each of you, if you want to share with us, we are about 120 people or so in the program. We want to share with us one lesson that you've learned over the last 4 to 6 months. Laura, you want to start?
Sure. I would say, it looks like most people are up and running again, but I would say that if you're still sort of hanging back from bringing people in, depending on what it looks like in your locality as far as number of cases, don't hesitate. People are having ED visits that we could prevent, and then you lose your capture if you wait too long. Don't hesitate, just ramp up and get your people in, because the time from discharge to the time they see you is still very important, and you want to make sure you get people in it as quickly as you can.
Excellent. Thank you. Jesse?
I would say the biggest lesson that we've learned so far is actually an insurance one. And we were surprised to find out that not all insurances will cover 2 visits of cardiac rehab in the same day when we do our insurance verifications. So we've been trying to keep track of what patients can only be here an hour and which patients can be here for the 90 minutes in order for us to maximize our billing. So that's been a little bit of a challenge for us here in South Bend.
Okay, very good points about insurances. Randy, any lesson you'd like to share with us that you've learned over the last 4 to 6 months?
Yeah, I guess one thing we've learned and can continue to learn over the years is that cardiac rehabilitation has remained relevant over the past 3 decades because it continues to evolve. And I would just encourage all who are engaged in provision of cardiac rehabilitation and participating in cardiac rehabilitation to continue that march forward with evolution to new methods, new ways of doing things that'll lead us to even better approaches. I would recommend caution. We have a safe alternative with home-based approaches, either as a prime source or an adjunct to center-based visits. But I would recommend caution as we face this pandemic, but realizing that evolution of cardiac rehabilitation is going to continue, and that'll make things even better for everybody.
Thank you, Randy. That's actually, I think, a very wise word about how cardiac rehab has evolved for the last 30 years, and I'm sure it will continue using the tools that we have available to us. And for last lesson from Tricia, as our patient sharing her perspective and insights from her experience. Any final thoughts, Tricia, there?
Yes, I guess my lesson learned was to trust the staff and make sure that I understand that they are there for me. In the beginning, is you don't know them, but if you can, to me, it's the ability to trust someone. So the lesson I learned is you can trust these people, and you are in good hands.
Thank you, Tricia. And I think that means a lot to all the cardiac rehab practitioners out there, that we are trusted, we are to be trusted by our patients, and so we just believe in our mission, in what we do. And so thank you for reinforcing that, Tricia. Our slide here has a link to quite a few resources that we've talked about and that our panelists mentioned. I think these will be available on the Take Heart website, and will be shared with all the 130 participants that we've had so far. Before we stop, we'll go to our last audience poll here that's that's showing on the right-hand side of the screen, and that will help us determine what you guys want to hear about, what you'd like to discuss for our next action group and webinar in September. I want to thank the panelists, Jesse, Laura, Tricia, Randy, and Karen for their participation and very insightful takes on what happened over the last 6 months and how we can continue to progress in the future. Thank you. So the question is, what issues do you think will be the most challenging for your program over the next 3 to 6 months that you'd like us to consider discussing in a future affinity group? And you can type it there.
Thank you very much for facilitating this, and it's been a great session with lots of really practical advice and insights. Welcome your comments to that. We're sensitive to the time. And so we'll just note in wrapping up that our next call is going to be September 16th at noon. We're shifting from a Thursday to a Wednesday to keep ourselves quick and nimble. We're still finalizing the topic, but we'll let you know and send out a registration for that link shortly. We want to encourage you to continue sharing discussions or comments online with your peers at that website, and all of the links and everything else from today's event will be sent out to you in the form of an email and also posted online. So thank you very much. If you have a chance to respond to our pop-up feedback questions at the end, that would be great. We want to continuously improve what we're doing, and your feedback helps us to do that. So thanks very much to our panelists, to the audience, and we hope that you have an excellent rest of your day and your week.